Good morning and welcome to Southern Maine Health Care's Medically Speaking. I'm your host, Robert Erickson, and for the next 30 minutes, you'll hear about medical issues and topics of the day directly from leading medical professionals at Southern Maine Health Care. My guest today is Dr. Paul Kim, Director of SMHC's Vascular Center, Director of Maine Medical Center Radiology Residency Research, and Assistant Director of Vascular and Interventional Radiology for Spectrum Medical Group. Our topic today is the causes, symptoms, and treatments for chronic venous disease and varicose veins. Welcome, Dr. Kim.
Thank you for having me.
So we usually start our show out by asking our guest a little bit about how they got into medicine, because it's interesting to find out how people make these decisions. Do you have a story about how you decided to get into the field of medicine?
Sure. It's not a particularly exciting story, but I think like a lot of students, I was an undergrad at Duke and trying to figure out what I wanted to do with the rest of my life. And, it came to the point where I realized I just wanted to pick a field where I felt like I could give back and contribute. And medicine at least seemed like the most direct way to be able to do that.
Now, obviously, when you go into the medical field, there are a lot of choices. A lot of different areas you can go into. What brought you into vascular medicine?
A few things. So with our field in vascular and interventional radiology, I had some exposure to it during some of my rotations as a medical student. And what appealed to me was the fact that it really was and still is considered sort of state-of-the-art, and the newest technologies that come about often filter and begin or even invented in interventional radiology. And they really specialize in using image guidance to do minimally invasive procedures. And to me, that was a big appeal, where I was kind of amazed at the things they could treat, the things they could do through just a small needle hole or a tiny nick in the skin, and that was it. And by the time they were done, really, there was almost no outward visible appearance that anything had occurred. And subsequently, patients went home quicker and they did well. So that was probably the first inkling I got that this was a field that I'd be interested in, because it seemed to really encompass both the clinical medicine but also have the sort of state-of-the-art and latest technology involved.
Maybe you could tell us a little bit about vascular medicine. As I understand it, it's the study of the circulatory and lymphatic system, correct? So,
in our field, there's within interventional radiology, there's a few different areas of expertise, and in our group, we've kind of subspecialized, if you will, to focus on these areas. For myself and one of my partners, Dr. Mitleider, we sort of specialize in the blood vessel aspect, so the vascular aspect. And what we do is, we're interested in both the arterial circulation as well as the venous side, the veins. And basically, that field revolves around, on the arterial side, trying to open up blockages and improve the circulation, usually to extremities in our situation. And then on the vein side, trying to improve the blood flow from, let's say, the legs back to the heart, which is a normal drainage pattern. And for a variety of reasons, patients may present with a problem with this type of pattern. And if there's a problem with that, then they often can develop significant symptoms.
Now, have there been big advances in vascular medicine, say, in the last 10 years? Is it different than the way it used to be?
Oh, absolutely, yeah. So I would say on both sides. So on the vein side, for example, the standard of treatment for what you may have heard of a DVT or a deep venous thrombosis, a clot in a leg vein, I'd say the 50 to 60 plus year old paradigm still holds true, where it's blood thinning as the main treatment. But things that we have been offering probably over the last decade, and it's starting to come to light a little bit more each time that it may be offered for more patients, is a way to actually go in and remove the clots directly. So we go in and dissolve these clots, remove them, and there's some evidence to suggest that it may offer a better outcome overall. Same thing on the arterial side. I'd say 20 plus years ago, all patients that had blockages in, let's say, a leg artery got a bypass surgery. And that's still definitely part of the treatment protocol to this day. But for certain patients, they may well benefit from a less invasive procedure where we use a balloon to stretch open the artery where the plaque is, or sometimes a stent. And then we also have some devices that kind of help carve out the plaque and remove it from the artery, as well as using some technology that actually imparts this medication either through the stent or from the balloon into the surrounding blood vessel to hopefully get it to stay open for longer. So those are kind of some of the important developments that have been happening in our field.
Now, if a patient comes to Southern Maine Health Care and they've got some issues, explain how someone would be admitted into interventional radiology as a patient.
So oftentimes, the primary care docs in the community do a good job about screening these patients, so they know, for the most part, the questions to ask, the signs and symptoms to look for. And then there certainly are several that we work closely with, and if they feel the patient is a good candidate, they refer them to us and we see them. And basically it's a outpatient consultation process where we evaluate them both clinically and then use some imaging to figure out, one, is the cause of their pain the circulation system, or is it something else? And then two, if it is a circulation, is it something that we can fix? And then afterwards, for the vast majority of these types of treatments we can offer at Southern Maine in Biddeford, and certainly it's been our experience. These patients really seem to appreciate the fact they can stay here at home.
Now, I noticed that you also work at Maine Medical Center. How does Southern Maine Health Care and Maine Medical Center work together on these kind of issues?
It works out well. So I would say, for this particular subset of patients we're talking about, probably 90+% of them can stay in the Southern Maine Health Care area. And these are patients that we can mainly treat as outpatients down here. A few of them we ask the hospitalist to assist us if they do need an admission to the hospital for a couple of days. And that's probably the vast majority. But there are a few patients that either have very complex, high-risk comorbidities as part of their background, or that we kind of know for one reason or another are going to be more high risk for the treatment. Those are the patients that we're grateful we have the ability to admit them and bring them up to Maine Med. And that way they are in a tertiary care system if we need those kind of resources.
Now, what are the main causes for the problems that people have? Is it mainly an aging process?
Or I would say for the vein side, to be honest, a lot of times we don't quite know on that side. So patients that present, let's say, with varicose veins, for example, the risk factors are pretty broad. So it's obesity, prior history of smoking, if in women, if they've had children in the past. So you can see it's a pretty broad categories. For whatever reason, these patients, male or female, can develop the situation where the veins just don't function as well as they should. And the veins' purpose, again, is to take the blood flow in the legs and actually drain the leg, bring it back to the heart where it's supposed to go eventually. And the way the veins do that is they have a bunch of one-way valves up along them. And for a variety of reasons, in some people, those valves just become leaky or they don't work as well. So then instead, the blood can pool in the leg instead, particularly with gravity pulling it down. And so it just has a hard time getting outside the leg. When that happens, that leads to varicose veins, other symptoms such as skin itching or burning sensation they've described. Leg swelling can happen, changes in skin color, and then the most severe cases, they can actually develop areas of skin breakdown or ulcers.
Let's talk for a minute about varicose veins. I think everyone is familiar with that, and maybe at some point in everyone's life there is some issue with that. People are familiar with, of course, the sort of the bumpy legs and then the dark blue veins. Are those both forms of what you would call varicose veins?
You're right. Basically, different forms or kind of a spectrum of the same disease. So those bumps or those very visible bulges, those would be the actual varicose veins that are produced, and then those kind of smaller blue or purplish streaks that you described, those can be classified as spider or reticular veins. Both of them can be symptomatic. They both can be tender to touch at times. At other times, they can be completely cosmetic as well. So it's important to be able to know sort of what questions to ask and figure out, are these just something that's visual, or are these truly causing symptoms?
So if someone has these kind of lumpy areas on their leg, particularly older men, as you say, is there some procedure where they can get rid of those safely? And is that a procedure that we do here at Southern Maine Health Care?
Yes, the short answer is yes. So for these types of patients, the process is we first see them, we kind of establish what their symptoms and their history is, and we do a special type of ultrasound where we try to figure out what the source of these varicose veins are. The idea being is that you actually want to eliminate that vein that's leading to these varicose veins or these spider or reticular veins. And it's essentially it's a simple outpatient procedure. We do offer it here at the Biddeford campus, where the patients they come in, and once we identify that vein, we basically put this small little essentially a laser tube or laser catheter into that problematic vein, and we place it under ultrasound guidance so we know exactly where we are. And then once we numb up that area, we basically turn on the switch to that laser and we slowly pull it back. As it pulls back, it actually seals off that vein, so it doesn't allow blood flow to go through that vein anymore. And then the idea being is that this vein that we treated is the main source to those varicose veins below. So once you eliminate the main source, it can decompress those varicose veins and essentially eliminate at least the main blood supply to them. In some patients where the veins tend to be larger, and we know that even after laser they still may be somewhat persistent, we do a secondary procedure at that time called phlebectomy. And it's a simple, essentially outpatient procedure where, same idea in a way, we numb up the skin near some of those bumps that you described. We make just a tiny little nick in the skin, and then using what's called essentially a vein hook, we can actually remove some of these, those larger, close to the skin veins. So the two treatments together, the laser and the phlebectomy, is very effective and very safe. Altogether, I'd say with both procedures, it takes about an hour or so for the treatment, and then afterwards they go home.
So once those veins are closed off or sealed off, is there the possibility of issues with circulation in those areas?
No, that's a good question. So usually, or in fact in all cases, no, because you have in your leg so many other veins. And that's what we actually want to do, is redirect the blood flow into those other veins, because those other veins have normal or intact valves. And right now, with patients that have varicose veins, the blood flow wants to take the path of least resistance, which is in this problem vein, which is in this big, it's usually a large vein where the valves aren't working and the blood flow wants to go there. So once you seal that off, it has to find a different path out, and that leads to the eventual solution.
Is the procedure painful for removing those veins?
Yeah, so what we do for the treatment is usually just before we get started, the patient takes a little bit of a relaxation pill just to kind of take the edge off. And then we use a medication to help numb up the skin. It's essentially like, if you remember, like Novocaine for teeth dental procedures. It's same type of idea, and we use this to treat that segment of vein that we're going to use a laser on before we actually turn on the laser. So once that's numb, then they don't feel anything. And same thing with the phlebectomy, same idea, is we numb up the skin and all of that before.
And I'm sure a lot of our listeners are wondering, is this the kind of thing that's paid for by insurance?
What we try to do first is establish that they truly have symptoms, and that's probably the first step. And then once we do that and we show that it's a significant clinical problem, then depending on their insurance, there are no further steps, and they go ahead and approve the laser. With some insurance carriers, they require a sort of a trial period of, you may have heard of like compression stockings or hose, support hose. And for one reason or another, they request that the patients try those for a period of time. It can be as short as 6 weeks. Some carriers request 3 months before they will approve it. And then once you demonstrate that they've tried it, but they still have symptoms and they're still there, then they go ahead and approve the laser treatment.
You're listening to Southern Maine Health Care's Medically Speaking with Robert Erickson. My guest today is Dr. Paul Kim, Director of SMHC's Vascular Center, Director of Maine Medical Center Radiology Residency Research, and Assistant Director of Vascular and Interventional Radiology for Spectrum Medical Group. And we'll be right back with Dr. Kim after this brief message.
Not every boo-boo is an emergency, but it still feels like one. That's why Southern Maine Health Care offers walk-in care. You'll find compassionate care at wonderfully convenient locations. Open 7 days a week, no appointment necessary. For those times when the unexpected happens, or you're just not feeling great, look for the orange ball as your sign of the best walk-in care. In Kennebunk, Saco, Waterboro, and Sanford, Southern Maine Health Care, a member of Maine Health.
And we're back with Dr. Paul Kim. Now let's switch topics and talk about deep vein thrombosis, which has been around for a long time, but I think a lot of people have seen it in the news, particularly the NBC News reporter who passed away from DVT after a long trip overseas. Maybe you could talk a little bit about deep vein thrombosis.
Sure, yeah. So that was probably, obviously the disease has been around forever, but that was probably one of the sentinel events that caused sort of a more raised public awareness. It's essentially when there's a slowdown of blood flow in one of your deep veins to the point where it actually clots it off. The most common risk factors are long periods of immobility. So if you ever, you hear about long international flights where you're kind of not very mobile, you're sort of stuck, in a sitting position for a long period of time. Or if you've had, surgery that causes you to be bedridden for some time. Those are some of the more common risk factors. Additionally, smoking is a risk factor as well. Other potentials would be women that are either on hormone replacement therapy with estrogen or certain oral contraceptives as well. Those are strong risk factors. Additionally, other things such as traumatic events to that leg can raise your risk. And then finally, there's a small percentage of patients that have some hereditary component where they're just more prone to clotting. So those would be the risk factors. In that particular example that you raised, he had been obviously traveling for a long period of time on the flight, and then actually I think it was when it actually happened. I think he was covering. I can't remember exactly if it was the Iraqi war, but he was with the troops, and so he was in a cramped position for a long period of time when he noticed his leg was starting to swell. So he definitely had that risk factor.
So talk a little bit about what causes deep vein thrombosis or DVT.
So if you have those risk factors, and basically any of those risk factors causes the blood flow to slow down in that vein, and blood flow doesn't like to be slow, because what happens is if it slows down too much, it just sort of gets thick, and once it gets thick, it's more at risk for clotting off. The problem with the clot is twofold. One is acutely, it can lead to leg pain and swelling. So that's the acute symptoms. But then the secondary problem is there is a definite risk of some of that clot breaking off and going to the lungs, causing a pulmonary embolism or a PE. And that can be a fatal event. So that's sort of the main immediate risk factor for that can be life-threatening. And then what we've learned over the years is there actually is a more chronic risk as well. Let's say you get past that early phase and you're on your blood thinning, is the longer that clot sits there in that leg vein, that's what can lead to damaged valves as well and damaged veins. And then even years down the road, studies have shown at least 1 out of 4 patients develop what we call post-thrombotic syndrome, where essentially it's a lifelong condition where you have leg swelling, pain, skin itching, burning, all those symptoms. And unfortunately, once you develop that, there isn't a whole lot that can be done. Leg elevation, those compression stockings, that's about it. But in some patients, what they have found is it causes them to not be able to be at all mobile, not be able to stand up for long periods of time. And it really has resulted in a big economic impact because they're no longer able to work or be that functional. So some of the newer treatments that we offer, and we also offer this at Southern Maine in Bedford as well, is a procedure probably easily known as thrombolysis or clot removal. The idea being is that you have to be on your blood thinning medication. That's been tried and true. But we also offer a minimally invasive procedure where we go into that actual vein and we give a medication called TPA that actually actively dissolves the clot. And then we use, same idea, either a balloon to help stretch open the vein or sometimes another device to help kind of suck out some of the clot so that hopefully 2 things happen. One is you get more acute relief of your leg swelling and pain, but then also it should reduce that risk of that long-term problem with leg swelling that you can get down the road.
So for people listening to this who maybe have a long flight, maybe flying to Asia, something like that, what do you recommend? What's the course of action to take if you're going on a long flight?
A lot of the airlines will offer this advice as well, but essentially, if you're going to be on a long flight, and I would define that probably longer than 3 hours or so, is get up and walk around when you can. Walk up and down the aisle. That's always helpful. Another is even in your seat, they recommend if you can do some like toe ups or calf pumps, where you're kind of flexing and extending that calf muscle, because what that does is the muscle squeezes the vein and causes the blood flow to keep moving. So those are simple things. Others. What people have tried and shown to be helpful is actually getting some of those compression stockings and wearing them during the flight as well. And then other simple things is, try to stay hydrated. So you don't want to, get too dehydrated on the flight, and drink a lot of water and that type of thing.
Now let's talk a little bit about chronic venous disease. Maybe does that encompass everything that we've been talking about in this interview, or what? How do you define that?
It's a spectrum of disease. So certainly varicose veins, the problems you get after a DVT, those are all part of the chronic venous disease issue. And that's essentially, I would say, the bulk of it. Either you have what we call superficial venous disease, which is the varicose vein component, and it can be symptomatic, or you have a deep venous problem or deep venous insufficiency. And oftentimes we find that's usually secondary to having a prior DVT. And in some patients, they never knew they actually even had a prior DVT. But those two components are the main drivers of that chronic venous disease.
Now, are there things that people can do with their diet that will avoid these complications?
The only thing really, there isn't anything food related. The only idea behind it is what's known to be a risk factor, or at least something that exacerbates the venous disease issue, is obesity. So if you do have, if you can lose some weight, it's been shown to at least improve your symptoms. If not, actually change the course of disease, it can actually relieve your symptoms to some degree.
We've been talking about varicose veins and deep vein thrombosis. What are the warning signs? What should people be on the lookout for if they have some sort of visible veins? When should they get them checked out?
So for varicose veins, if you do have those symptoms of leg heaviness, swelling, itching, burning, or aching sensation, they often describe, that's when it's probably time to talk to your primary care provider about the fact that you feel not just that you see these veins, but that they may be the source of what's going on. It's always possible they're not, but we won't know until we sort of evaluate them. What some people believe is that varicose veins are just simply cosmetic. And in some patients that's the case, but in others it can actually lead to pretty significant symptoms where it results in reduced activity, particularly with people that maybe stand for long periods of time for their job. They have a hard time completing their shift, or they just notice it more and more, and they're miserable. And to me that's been striking, is that it can really be a significant impact on their quality of life, these varicose veins. With deep venous thrombosis, probably a critical sign is usually it is fairly acute onset, or at least sort of rapidly progressive, where you notice your lower extremity, your leg starts to become more swollen and painful. If you notice that, it's definitely not something to be ignored, because it's a pretty simple study that is performed to evaluate it. Let your primary care provider know, either through their office or through the emergency department, or they can order an ultrasound study in the radiology department, and it's something we do very commonly for those two exact symptoms. And with that simple study, it takes maybe 15-20 minutes, and it's not at all painful. They can diagnose whether or not there's a DVT or not. And then if there is a DVT, immediately, depending on its location, you would start treatment with a blood thinning agent.
Now, you just mentioned people who stand a lot at their job. What is worse for the circulatory system? Is it standing a lot at your job or sitting at your job?
Overall standing. And the reason being is that you have gravity working against you. So in these veins that are either clotted off, or if the valves aren't working, you have gravity pulling the blood flow back down into the leg. And then, again, the purpose of the veins is to get the blood flow out of the leg. So you have gravity working against you when you're standing up, and that's what you'll find. So people that, let's say either stand at a register for long periods of time, or waiters or waitresses or bartenders, those are particularly the ones, or any sort of job where they feel like they're on their feet for most of the day. That's what they notice is by the end of the day, their symptoms are much worse than at the beginning of the day.
So there's no orthotics that would make a difference necessarily. It's all about blood flow, correct?
Correct, yeah. So no orthotics. Those compression hose or stockings can be helpful to at least relieve some of the symptoms.
Let's talk about age now. What ages do you see when you're treating people for DVT or varicose veins? I mean, obviously it's a factor. What have you seen?
For both diseases, both the varicose vein issue as well as the DVT, for the varicose vein issue, we've seen pretty much all comers, from patients in their 20s with large varicose veins and symptoms to patients into their 80s. And both genders seem to be fairly equally affected. We sort of start to take things into account, especially in the elderly, how much the veins are actually bothering them. Obviously, as you become more elderly, we take into account how much does it really affect their quality of life, and how active are they, because that should play an important role in figuring out what's the best treatment for them. Probably in some of those patients anyways, less is more. So those compression stockings may be all that we prescribe, but in others, certainly a more definitive treatment would be offered. And the durability, fortunately, appears to be quite good, is what the data suggests. So even the patients that we treat that are quite young, it's extremely rare for them to come back to us ever in their lifetime saying, okay, they've come back, we need another treatment. So that's been good news to us. With the DVT treatment, it's all comers really. So we've seen even patients that are in their teens that present with acute DVT, unfortunately. Some of them have those risk factors I discussed. Others have that hereditary disorder. And then there's, in certain subset of patients, just those that are more prone to forming clots. And again, depending on their presentation, their age, and usually with the help of either their pediatrician or often with a hematologist, a blood specialist doctor in that younger age group, we decide whether or not to do that more aggressive treatment where we actually go in and remove the clot. The vast majority of patients, however, I think we see with DVT are probably 40s and above. And same idea. The idea is you want to thin their blood as soon as you can. And then after that, consider whether or not the clot removal procedure is right for them or not.
Is there an age on one side or the other, either young or old, where you wouldn't work on somebody for varicose veins?
So varicose veins, I'd take the upper edge of the age spectrum. At some point, because really with the varicose veins, the fortunate thing is it's not a life-threatening usually or a limb-threatening type of condition. And even if they have significant symptoms, it really is a quality of life decision. So for patients that are not very active, maybe more elderly, and those patients probably take it with a grain of salt. They may well have the disease, but talking with them and their families, see if they really want to do the treatment or not. If it makes sense that way. You can treat it, it's overall a safe procedure, and they'll do well with it. But that being said, there's always a little bit of risk with any sort of procedure. So we really want to make sure we're doing it for the right reasons.
Now, a lot of women who are pregnant get varicose veins. Is that something that you would treat, or is that something that naturally goes away after the pregnancy?
So, yeah, that's sort of a special subset. The most probable reason as to why they form these varicose veins are as their uterus gets larger, there's more pressure in the pelvis. It is compressing actually some of those pelvic veins way up there, and that leads to increased back pressure on the veins below, which would be in the legs. And so what can happen is you start to see varicose veins during their pregnancy. I don't know the exact percentage. Some of them will resolve on their own upon delivery. The uterus starts to get smaller, the veins decompress, things improve. But definitely that is one of the risk factors for varicose veins. Over time, those valves being under that pressure, they just don't work as well. They become leaky. And when that happens, then even after delivery, those veins can persist. And part of the problem is once those veins are there, you have gravity working against you, and so they can actually get worse even after delivery and still be symptomatic.
Do you have any recommendations where our listeners might go if they want to get more information about varicose veins and DVT?
Sure. So, probably the best initial source is their primary care physician. They certainly are aware of both entities and can provide them with some information and then point them in the right direction to get more in-depth information. Two easy websites probably that may help stick in their memory. One is mainvascular.com, and then you just click on the varicose veins or DVT icon, and that will give you, it has sort of a frequently asked question type of section and potential treatments and that sort of thing. And the other, which is sponsored through our society, the Society of Interventional Radiology, is varicosveindoctor.org. So they just type that in, and it'll take you to our society's website, and it has all the same sort of information and potential answers to most of the commonly asked questions, and then some further resources and also the references as to where they got this information.
Well, we've run out of time for this week. My guest today has been Dr. Paul Kim, Director of SMHC's Vascular Center, Director of Maine Medical Center Radiology Residency Research, and Assistant Director of Vascular and Interventional Radiology for Spectrum Medical Group. Dr. Kim, thank you for sharing some time with us.
Thanks for having me.
Join me next week at this time for a new guest and an enlightening discussion about healthcare in our communities. Brought to you exclusively by Southern Maine Health Care, your trusted resource for healthcare in Southern Maine.